Technical comments about how to perform the PET-CT in children. For sure, many of the things that I am going to say, that you know that very well, but I think it's quite interesting to review that at the beginning of this workshop. For PET-CT in children, we need the best devices with the highest sensitivity as possible. On the right, you have a device in Copenhagen in a pediatric hospital, the Rigshospitalet. On the left, it's our device in Barcelona. It's a time-of-flight equipment from Siemens with a very large bed. And it's fantastic to detect the children because we can inject a very, very low dose. And what about the implementation of PET-CT in children? Well, we have to have in mind the child management. The PET-CT devices have a very big size, and for this reason it's difficult to access the children by the parents or by the technologist during the image acquisition. The child and the parents have to receive information before to perform the technique. We need the parents' collaboration and their consent, if possible, that they written consent. And the child preparation is very important. The child has to come to our service in fasting conditions, and very often we have to give them the pharmacological preparation. We have to calculate, as detailed before, very adequately the dose calculation. The dose administration is also very important. And very often in PET-CT, we have to require the anesthetist to acquire the images. These are the guidelines of the EANM, but recently guidelines of both societies from the SNM and the EANM, they published consensus guidelines for the pharmaceutical injection. Okay. And now we are going to review some differential aspects in pediatrics. The first one are the indications. What about the indications? In oncology, the PET-CT is very often indicated for the initial staging of an oncologic disease. And more and more often, they ask us to perform an interim PET-CT study. For example, in lymphoma, after 2 cycles of chemotherapy. Sometimes they require another PET-CT at the end of therapy or for therapy planning, but there are more and more indications and non-oncologic indications. One of them is to discover the focus of the fever of unknown origin with quite good results. And also the rheumatologist ask us for PET-CT in systemic diseases like inflammation, still disease, or immune diseases, or even in infection. For example, last week we performed a PET-CT to discover if a child has an active tuberculosis or not. There is no evidence in children, but yet yes in adults, and in this child we discover positive with high uptake lymph nodes in both periiliar areas. What about the appointment? The pediatrician or the oncologist has to ask us to perform an application, and we have to review this application in order to know if the indication is correct. And we have to inform about the procedure and the preparation to the family if it is an outpatient, or to the nurses if the child is admitted in the hospital. Referring to the preparation, when the child arrives to our department and before injection, the nurses perform a short anamnesis, and the key points of this anamnesis are the previous surgery, radiotherapy, chemotherapy, and when. They have to ask for recent inflammatory diseases, and especially for oropharyngeal or bronchial infections, in order to discard false positives of our scans. And also we have to ask about recent trauma. Referring to the information and the written consent, in fact, on the office, the pediatrician or the oncologist have to inform the parents about the indications, the benefits, and the alternatives of the exploration. And in our department, nuclear medicine, we have to inform them about the acquisition time, the equipment, the dosimetry, etc. It is advisable for us to give this information in a brochure and orally also by the nurse of the technologist. It is advisable, and in my country is mandatory, to obtain a written signed consent from the parents or the tutors. And when the child arrives to our department, she has to find a pleasant atmosphere with toys, television, music, so that, and a good predisposition of all the team. The child management has to be performed by experienced pediatric staff. This is a very, very important point. For the preparation, the timing before administration and detection. The child has to be addressed with a bed or an armchair 15 minutes before the tracer administration, and minimum 45 minutes after the FDG administration. We have to avoid sweets and chewing gum, even without sugar, because they activate the mastication muscles, and the sugar can increase the glycemia. And before imaging, 45 or 60 minutes after the injection, we have to ask the older children to micturate, to drink liquids, and to eat some food in order to profit from the relax after the meal to obtain the images. Remember, avoid sweets and chewing gums, prevent the child to speak too much, and try to have a comfortable room, calm for the rest of the children. Sometimes we have to use some toys or mobile phones, like here, because they rest more than without. What about the fasting conditions? The fasting conditions has to be only 3 or 4 hours in small babies, and 4 hours, but recommended 6 hours in older children. Before the injection, you have to test the glycemia, and we administer furosemide in order to increase the urinary drainage. And if an anesthesia is not planned, then we give a soft meal 45 minutes after the FDG injection in order to have relax after the meal and to win the best collaboration of the child during the detection. We can inject FDG if the glycemia is under 160 milligrams per deciliter. And about the pharmacological preparation. The pharmacological premedication is basically in order to reduce in children the brown fat uptake. Usually we don't use premedication, a pharmacological one. We use only thermal pillows and heat in the room, but sometimes we use beta blockers. The brown fat uptake, as you know, is very frequent in children, and especially in girls, in teenagers, and in case of lymphoma. When we have to use beta blockers, then we use these doses that you can see here. Okay. The most important thing to diminish the brown fat uptake is to avoid cold temperatures 24 hours before the test. And in our department, to heat the room, waiting time in a heat room for 15 or 20 minutes before the FDG injection, and to use a thermal pillow. And if we know that in a previous PET the girl has a fat uptake, a brown fat uptake, then we ask the family to come a half an hour before the injection, and in order to prolong the heating time And then, yes, we use the beta blockers. This is the thermal pillow that we use. Is the same that they use in the post-surgery areas. We always use it, and it's big enough to completely cover the child. And we use usually 15 minutes, but if necessary, 30 minutes before the FDG injection. But it's not always useful, and sometimes, for example, now at the beginning of the winter, we have brown fat uptakes. About the FDG injection, we have to put a needle, an intravenous needle in a peripheral vein. It is advisable to put that in the contralateral arm of the tumor, and always that the nurse has to test the vein permeability with saline serum before the FDG injection. And after the FDG injection, they have to wash the vein with a quite big volume for a child of saline serum to clean adequately the vein of injection. What happened in case of central catheter? We use that only in exceptional cases, but we use this via. When we have to use a central catheter to administer the FDG, we dilute the dose in order to diminish the catheter wall deposit of the tracer. And it's useful, and we don't have artifacts using this technique. But the volume of dilution is quite big, and you have to inform the pediatricians that, for example, in a 4-year-old boy, we have injected in order of 50 milliliters of serum to apply this technique. And what about the bladder catheter? In some departments, they use it routinely. It's exceptional in our department. We prefer to perform, if necessary, a second point PET with furosemide administration, hydration, and micturition. When do you perform that? In case that we have to value very adequately the region of the pelvis, in case, for example, of a soft tissue sarcoma, or when we have a ductful cases of spots of the urinary drainage. Referring to the dose calculation, Tim has explained a little bit that the pediatric dosage chart is based on the weight of the child. It is advisable to use a 3D PET acquisition in children because with this technique we can diminish the administered dose, and we have to quantify the injected dose using the pediatric dosage chart of the EANM. Well, as said before, the atmosphere in the service has to be as quiet as possible, and during the PET acquisition, the father, the mother can be present. The nurse or the technologist, it is advisable that he can be present, and we have to have a good relation with the child. We can read a book, we can put music, songs, etc. And the physical contact is very important, and we have to contact the child during the acquisition, and that means that he will be more calm than without. What about the immobilization? The immobilization is basic in babies under 2 months of age. They are fast for 4 hours. FDG, and then after 45 minutes we give them milk. We put them in a vacuum pillow, and usually they sleep. And when they sleep, then we scan them. That means that under 12 months, nearly never we don't perform anesthesia or sedation. With children older than 5 years, we have to obtain the collaboration, and anesthesia is not very often necessary. Only we have to apply anesthesia in case of mental disorders. And the problems are the children between 1 and 5 years. In these cases, we always order an anesthesia, and only in few cases of really exceptional children that they visit us or they visit the MRI department quite often, in some cases from 3.5 or 4 years, then we don't need anesthesia. But we prefer to have the pediatric anesthetist there and to decide at the last minute. And this is the show that you have for an anesthesia on the PET-CT. The pediatric anesthetist is who is going to do the procedure, and our technologist prepares the room for the anesthesia. In babies, no anesthesia, PET after a meal, physiologic, 1 to 5 years anesthesia. And remember that when we are using anesthesia, the pharmaceuticals cannot be administered before 20 minutes after the FDG administration in order to avoid interferences with the FDG uptake. What about the equipment? If we have to have a very good PET-CT device with a high resolution and high sensitivity, we will need also a device to inject the intravenous tracer. And for the acquisition, about the CT. Remember that the CT represents 2 or 3 times the dosimetry of the FDG. But in fact, we need a diagnostic CT with a low dose but diagnostic and with intravenous non-ionic contrast in case of lymphoma or in case of suspicion of lymphoproliferative disorders and in neuroblastoma. In some other indications, we can use a very low dose CT, non-diagnostic CT, only for attenuation correction, for example, in sarcomas, in Langerhans cells histiocytosis, or in cases that we have a whole body magnetic resonance image performed the days before. In any case, the kilovolts and the milliamperes of the CT have to be consented with the pediatric radiologist of the hospital. We have to avoid the CT repetition, and we can administer oral contrast under the pediatric radiology criteria, and the intravenous contrast has to be administered always in all the cases in which we want to value the lymph nodes. These are the doses of the diagnostic CT of the PET-CT that we are using in our hospital. They are adjusted to the weight and to the area of the body. And remember that the CT dosimetry is 2/3 of the total dosimetry of the PET-CT, and it is very important to adjust the kilovolts, the milliamperes, and also the thickness and the distance between the slices of the CT. Quite often, just for attenuation correction order, we can diminish the thickness and the distance between the slices. And this is the things that we are doing in my hospital. We try to perform always a whole body, and the whole body is mandatory in any case in Langerhans cells histiocytosis, in neuroblastoma, in suspicion of distant metastasis. We can perform 1 or 2 acquisitions. 1 acquisition if it is a collaborative children or if we perform anesthesia, and 2 acquisition in less collaborative children. 1 acquisition means a lower dosimetry, and the thing that we discovered is that we can detect the legs only with PET, without CT. And if we find any abnormality on the legs on the PET, then we perform 1 bed of PET-CT on the place of the PET abnormality. This is the summary of the procedure that we use in my department. In case of lymphoma, lymphoproliferative disorder, sarcoma, neuroblastoma, histiocytosis, fever of unknown origin, inflammatory or infectious diseases, we perform a PET-CT from skull to the half of the femur, and the legs, PET without CT. We administer intravenous contrast, and we perform a CT, diagnostic CT, but with a low dose. And in case of a PET with fluorine, this procedure is performed in my hospital in a suspicion of child abuse, infection, bone viability, as we can explain later, after sepsis, surgery, or bone graft. Then we perform the PET without CT, but with a full body PET. And in battered child and infection, we perform 2 PETs. One, it's like a blood pool image. We inject on the equipment, on the PET CT, and immediately we acquire 1 minute PET acquisition to obtain an image of the full face. And 45 minutes after the fluorine injection, we obtain the whole body PET. That means is the bone face of the PET CT, of the PET. And then we can obtain PET CT or localized X-ray images of the detected lesions. And what about the results? I am going to finish with showing you some examples. This is a 2-year-old boy with Langerhans cell histiocytosis. This study has been performed with anesthesia, and we can see here the images of all the body. Can you see some abnormalities? Okay, well, here it was some abnormalities here on the neck, and I think that on the clinical cases we will see this boy. This is another case. This is a lymphoma. As explained before, we have a first scan of the head, the neck, and the body till the half of the femur, and the legs are acquired separately without the CT. In this case, for the body, we have a diagnostic low-dose CT with intravenous contrast, and you can see the big lymphatic disease on the left part of the neck, but also multiple nodes with a high uptake on the over and under the diaphragm and affecting the liver. And these are the legs of the previous case without CT. And you can see that there are several bone marrow incidental findings not detected by the whole body MRI, because usually the whole body MRI, at least in my hospital, they stop the image at the half of the femur, and in a retrospective analysis, we find that approximately 15% of the children have findings in the legs not detected by MRI or not detected by a PET stopped in the half of the femur. This is one case of a neuroblastoma. In neuroblastoma, you know that these children can have metastasis until the feet, and that means that we have to include the whole body image, including the legs. In case of sarcoma, we obtain always a whole body image of all of the body. This is an osteosarcoma, a very advanced stage of osteosarcoma of the right femur. And this is another case of Ewing sarcoma of the thorax. And the PET CT image shows very well the lesion. And before writing the report, we have to know very well the normal variants of the PET in children. The first thing different from adults are the metaphyseal plates activity. You know that very well. The bone marrow activity, remember that like for the gallium images previously, the bone marrow activity is higher in children than in adults. The thymus can show very often, especially after chemotherapy, a very high uptake. And where a tricky point is to look at the this uptake is diffuse or if it is multinodular. The Valdeir ring is very often quite difficult to value, because sometimes you can find only the activity on adenoids and the amygdala, But quite often we have some activity on the retropharynx, and it is very difficult to report this kind of things. And the brain maturation has been described by Shugani 30 years ago. The false positive results can be on the left. You have the false positive in adults or in all the population, and on the right the false positive in children. The most important thing is to remember the thymus activity, the brown fat, and the sequela of the radiotherapy, the bone marrow, and the infection. Okay. This was one case of a boy sent to us under the suspicion of lymphoproliferative disorder. He had a severe immunodeficiency, and we found a lot of lymph nodes with quite high uptake on the neck, but also on the mesenterium. He has been submitted to a biopsy on the neck, and the diagnostic was lymphatic hyperplasia, not lymphoproliferative disorders. That means that it's very, very difficult to interpret this kind of scans in children. And how do we do our reports? The report in my hospital is done in combination by a nuclear medicine physician and a pediatric radiologist. It is an integrated report with an exhaustive description of all anatomic and metabolic abnormalities. Here you can see one of the points with higher difficulty to interpret. In lymphomas, it's very important to differentiate lymph node activity on the ileal area from the pulmonary activity. And I think that the radiologists have often some difficulties in this differentiation. And some words about PET MRI. PET MRI is theoretically the best imaging technique for pediatric oncology due to the lower dosimetry without CT, and because MRI and PET are the reference techniques. But as mentioned before, PET MRI has a very, very long acquisition time with important technical problems like interferences within the magnetic field and the radiation. And in fact, the PET image is worse in PET MRI than in PET CT. And also the cost of these devices is very important. And on the other hand, for us, it's quite easy to compare and to interpret the PET and the MRI separately without fusion, making a correlative imaging, or with manual fusion. And well, sometimes if we don't have these devices, we can use these both techniques to make our report. Correlative imaging improves the oncologic diagnostic. And I think it's very important the collaboration with the pediatric radiologist and the interpretation of the correlative imaging. PET CT or PET CT MR are crucial for a good diagnostic in pediatric oncology. And it's all. Thank you very much.